6 hours, so we'll be cutting 1 minute short for each of them the way it looks. So if you can manage, fine. Otherwise, we won't mind. Question and answers will not be asked now, so we save on that time. And duration is 5 minutes, of course. Changing of the presenting author is not allowed. I hope the original names who are given are very much there. Members number from 27309 are all ratified. Beyond that, they will be not there for the awards. Absentees, you need to indicate clearly as absent. Let's start the session. The first talk. Can I have the list of the talks that we have? Yeah.
Papers.
The first talk is stratifying the risk factors affecting outcomes in open globes injury using AI. Presenting author is Dr. Garirik Kundu. You are there, sir? I would like to have the next person here, Dr. Divya NP. Also, is she there? Yeah. So we save on time, that's why. Let's try and stick to the time, sir. Let's start.
Yes, sir. Thank you, sir. So I'll be speaking on stratifying risk factors affecting open globe injuries using AI, our 10-year data set. I have no financial interest. So of course, we're a lot of talks on penetrating trauma. We're aware of the fact that it is an emergency. It's one of the most common encountered emergencies in the ophthal OPD. And the way we assess it is, I think, kind of common. Having said that, there are various ways of managing, prognosticating these, and it's very, very important that we kind of manage them quick, manage them right, so that we can improve their long-term outcomes. When we're looking at prognostication and factors, there are a lot of scoring systems, OTS, BETS, which looks at preoperative factors which can affect postoperative outcomes. Many of them are, of course, known. You're looking at age, you're looking at preoperative visual acuity, the type of injury, the severity of the injury, posterior segment involvement, cataract. Having said that, a lot of work has been done on factors I've told, but in the Indian context, many more factors in terms of, if you look at demographics, the gender, the place where they come from, socioeconomic profiling, their income, and how much time those patients take to come to the center. These are also factors which can actually affect the way we're, looking at these injuries and how it can affect outcomes. So why did I use AI? There are various ways of analyzing this data set. We had a data set of 10 years, multiple time points, over 1,000 eyes. AI kind of gives you, risk stratification scores, and that is the reason why I used AI in kind of analyzing this data set over the last 10 years. So my research question was on using AI to stratify preoperative factors. I looked at 1,324 eyes. This was, patients who had primarily undergone corneal tear repair, corneal skill tear repair, or skill tear repair. These were categorized. They had a minimum follow-up of 2 years, as good or bad outcomes after 2 years. And we also looked at the factors which I told. Specifically, we also added demographic profiling, socioeconomic strata, their income levels, and how much time they actually took to come to the hospital. And I incorporated an AI model. So just to simplify and cut it short, there are a lot of classifiers which you use in AI. One of them is known as a random forest classifier. What are these? These are basically decision tree classifiers which help in kind of stratifying and separating out the data. There are other model classifiers as well, something known as SVMs and neural networks. And what we found in our cohort is the RF classifiers are the most accurate. But having said that, the most basic steps of how we create an AI model is put in the data, use a part of the data for training and testing, and then finally, validating the results. That, however, stays common irrespective of the type of classifier. And this is the software which we used. So, when we looked at the 1,324 eyes, the median age is, I think, concurrent to previous results. Of course, younger population more prone for injuries, a lot of workplace injuries. Interestingly, pediatric population formed almost 39–40% of the injuries, dealt with at our center over the last 10 years. The AI model, in fact, was quite accurate. There are some parameters which we use, such as the area under curve. We also use the confusion matrix. Now, what is interesting is, in terms of the factors which the AI picked up, we normally would think it would pick up factors such as cataract, posterior segment involvement, no doubt, but a time to the hospital with a cutoff of 4 hours was surprisingly a cutoff picked up by the AI, and this also correlated well with the place of residence, which was not in the city where my hospital is located, and it was also correlated with the income level. So multiple referrals, increasing the time to the hospital, played an important role, and that was the second most important factor generated or detected by the AI. So we are, of course, aware of the fact that traumas is a huge burden, especially in in our country. The fact that we need to triage, treat them early is important. What I try to basically look at is the fact that known factors will not change. The extent of the injury, the visual acuity, cataract or retinal involvement is not going to change. But unfortunately, the modifiable factors is something which we need to look at, which includes, triaging, referring. There needs to be a better system of referrals, and that in a long way can help in prognosticating outcomes. Thank you.
Very nice study. All the retrospective, how much? 1,000 plus is the number I just saw. So fantastic. That's very nice. Thank you, sir.
Thank you, sir.
Any questions you want to raise?
Did you compare it with the bets classification?
So we did do bets. What we tried to look at is additional factors in our context. For example, many of the patients, of course, they do have, you're looking at the extent of injury, the type of injury, but demographic factors in terms of their socioeconomic status, how much time they actually take to come to the hospital, and how many referrals. And that what we found is picked up as one of the important parameters, which is trying to tell me that we cannot change the fixed factors. But the modifiable factors, such as triaging or referring it quickly, is something which we need to work at.
Apart from the classification.
We looked at OTS, we looked at bets, classified these
trauma
patients.
scoring
Yes, sir.
And apart from those parameters, you have compared.
Looked at demographics as well. Yes, we've added that as well.
Very
Can we have the next speaker here, this side, Dr. Uttara Ravidas? Is she there? Yeah. Please take the podium on the other side. Ma'am, you can start.
Good evening, everyone. I'll be talking on anatomical and visual outcomes in post-traumatic pediatric retinal detachments. So, ocular trauma constitute about 8 to 14% of total injuries, which is the major cause of non-congenital unilateral blindness. It can be divided into open globe injuries and closed globe injuries. And retinal detachment due to these injuries is a threat to vision due to delayed diagnosis and immature visional system. There is higher risk of macular involvement and higher risk of developing PVR also. So we did this study to know the retinal reattachment rates, the visual outcomes, and the factors affecting the outcome. This was a retrospective study done from January 2019 to December 2022. It was a single-centered study, was done after IEC approval. A total of 112 children were taken, aged between 0 to 18 years. With a minimum follow-up 6 months. Myopia and vitreoretinopathies, amblyopia, congenital cataract, and glaucoma were excluded from the studies. A total of 112 children were included, out of which 91 were males and 21 were females. Open globe injury was more common than closed globe injury. At the time of presentation, clear lens was noted in 41.1% of cases, cataract was seen in 53.6% of cases, and subluxation or dislocation was seen in 5.4% of cases. So macula on RD was seen in 53.6% of cases, and macula off in 46.4% of cases. Grade C and D PVR was more common in all these cases. So during the initial surgery, lensectomy was done in 66% of cases, for which out of them which 59.45% IOL was placed in the first setting, and remaining 40.54% were left aphakic. They were managed with aphakic glasses and contact lenses. So we found a significant association with PVR grade and the reattachment rates. Lower the grade of PVR, better the attachment when compared to the higher grade of PVR. So vitrectomy was the most commonly done surgeries in primary and resurgeries, followed by vitrectomy and encircling band and scleral buckling. So retinectomy was done in 12.5% of cases in primary surgery, and in 71% cases which in resurgeries 1 and 60 in 5 cases of resurgeries. So silicone oil was the most common tamponade used both in primary and resurgeries. Out of 112 eyes, 73 eyes went plain SOR, and 39 eyes, both gas filled and silicone oil filled, underwent multiple surgeries for redetachment under oil. So this is the first picture shows extensive subretinal gliosis, and the second picture shows SRG removal, and the third picture shows post-op attached retina. So out of the total 112 eyes, 11 eyes required the trabeculectomy due to sustained release of IOP, and 12 eyes went for phthisis bulbi. Clear eye was found in 83.9% of cases, and 18 cases had corneal scarring, BSK, and phthisis bulbi. So the most common cause of injury in our study was scissor, opal globe injury was scissor, pencil, pen, and stick injury. And closed globe injury most common was due to cricket ball, nerf guns, and while playing gilli dand. So retinectomy was most common in resurgeries. Anatomical success was achieved in 79.46% of cases, and 10% of cases developed phthisis bulbi. So pre-op visual acuity was initially low due to the associated corneal edema, hyphema, and vitreous hemorrhage. Single surgery has better visual outcomes than resurgeries. Children undergoing multiple surgery has higher grade of PVR, and the risk of redetachment was also more, and which adversely affected the functional outcome. So 38.39% of children had visual outcome of 1.1 to 1.7 logMAR units at the final follow-up. So, and in the conclusion, traumatic retinal detachments need early recognition and appropriate surgical intervention. Higher grade of PVR associated with more number of resurgeries and worse anatomical and visual outcomes. It is possible to achieve reattachment in eyes with prompt assessment of PVR causing reattachments and performing surgery. Pediatric population are susceptible to traumatic eye injuries, and programs for knowledge, prevention, and awareness are necessary. So limitations are which are inherent to retrospective study. These are my references. Thank you.
Very nice. Now, what is the reason for that 44% remaining fake kick with so much of?
Sir, most of the times the globe in the eye, children are not well developed. For those cases, we left the child aphakic, and once all the retinal detachment, all the trauma, everything settles, we were going for the secondary IOL implant.
So the vision that you have taken is after the secondary IOL implantation, or it is before that?
After secondary IOL implantation.
After the implantation. How long has been your follow-up for these cases?
It's a minimum of 6 months to 2 years of follow-up we are taking.
2 years. And all the fake kicks you had operated within 6 months of that?
Yes.
That is what it is. Okay, thank you. Any questions? Anybody? Yeah, you can start. Next. Anterior segment optical coherence tomography and management of closed globe injury, right? Yeah. The next author, Raj Vedor. Can you come this side, please? Dr. Raj, is he there? Raj Vedor? Vedant Rajoria? Not there. There are two. Pragati Tiwari? Yeah, please. Absent, might kar lo, sir. No. Yeah, you can start. Sorry.
Good evening, everyone present here. My topic of discussion is anterior segment optical coherence tomography in management of closed globe injury. Ocular injuries are one of the leading factors in development of long-term monocular visual impairment. In closed globe injury, full thickness of the eye is not involved. It is divided into lamellar laceration and contusion. Spectral domain optical coherence tomography is used for anterior segment imaging in our study. It is a rapid non-invasive modality that uses superluminescent diode emitting at 840 nanometer wavelength. It provides in vivo real-time structural information of ocular surface, cornea, and anterior chamber. The purpose of the study is to detect alterations in anterior segment of the eye following closed globe injury with the help of AIOCT and its role in management of these cases. This is a hospital-based cross-sectional study conducted over a period of 6 months. 25 patients above 11 years of age diagnosed with ocular trauma attending Department of Ophthalmology were included in this study. Patient aged 12 years and above presenting with closed globe injury due to mechanical trauma were included in this study. Patients with chemical, thermal, and radiational injury were excluded. Patients with any pre-existing ocular disease, non-ambulatory patient, and patient who could not provide informed consent were excluded. All patients underwent thorough clinical evaluation including details regarding age, sex, occupation, along with systemic symptoms, ocular complaints, treatment history, general and local ophthalmological examination. Classification of ocular trauma is done on the basis of type of injury, visual acuity, grade, and zone of injury. These patients were then subjected to spectral lobar anterior segment OCT. 25 eyes of 25 patients were examined in our study. This is a bar diagram showing age distribution of anterior segment injuries. Highest incidence is seen between 41 to 50 years age group. Coming to intersegment findings, corneal findings, corneal edema had highest incidence, followed by corneal decimens membrane rupture. In interchamber findings, uveal tissue and lenticular findings are tabulated here. Hyphema, 11 patients had hyphema, and enters angle recession and iridodialysis. Four patients had angle recession and iridodialysis. 2 patients had iridodialysis. This is the bar diagram showing the same data. In figure 1, angle recession is shown. Patient had hyphema along with angle recession. In the second diagram, subluxation of lens is shown, and decimens membrane folds were seen in the third picture, and iris tissue tear with hyphema shown on the third picture. The patients with closed globe injury may have severe corneal edema and media opacity, making it difficult to assess presence of other intersegment complications. In our study, 5 cases with contusion injury of the eye had corneal decimens membrane damage detected with ASOCT, which slit lamp examination could not detect. These patients were treated accordingly. Vailigala et al. In their study reported that ASOCT revealed decimens membrane separation, also showed acute angle closure and pupillary block with blood-stained cornea. 15% cases had hyphema occupying more than 50% of anterior chamber. Among these cases, in spite of hazy media, iridodialysis is detected in 8% cases. Urban et al. In their study found that high resolution documentation and simple visualization are both offered by ASOCT. 12% cases had traumatic hyphema, which showed angle recession. These patients were closely monitored for any spike in IOP. Topical aqueous suppressants were used in these cases, which raised IOP. These patients were made aware of future surgical interventions if IOP is not controlled with medical management. In summary, the intersegment OCT was effective in obtaining high-resolution pictures. It was helpful in evaluation and treatment planning of these cases. It is a non-contact imaging modality. It offers benefits of reproducibility and precision. Clinical imaging is crucial in visually dependent disciplines, and these images used in our study gave access to extra information that would not have been otherwise known. These are my references. Thank you.
Thank you very much. We have the next speaker. Any questions from the panel?
Which classification was followed for the closed globe injury?
Birmingham Eye Trauma Terminology classification.
Birmingham classification. And how did you manage the decimens membrane detachment?
Ma'am, we gave the patients hypersole, and then we observed the patients, and then many of the patients were.
But there was no detachment. I think it was deciment membrane
Folds,
folds.
yes,
Folds were there.
folds.
But this, what difference will you find? Because grossly, I don't think you have got anything extra from slit lamp examination. Because angle recession, you cannot rely on this. You have to do gonioscopy when the hyphema resolves.
Yes,
So what I feel is slit lamp is still the gold standard. Because you can see the folds on the endothelium or in the cornea by slit lamp. You can see hyphema on slit lamp. You can see subluxation which you have found on of the lens on slit lamp. You have to do gonioscopy for confirmation of angle recession.
Yes,
And in the presence of hyphema in the anterior chamber, you cannot see the by this ASOCT. So I think still we cannot avoid doing slit lamp examination.
We cannot replace slit lamp
Yeah, we
examination.
cannot
This is a
replace
new
it.
modality, sir.
So
That's
in
right.
It can, but nothing extra we have got from this.
Yes, sir.
What we can achieve from by the slit lamp examination. But you can substantiate or document it by doing this. Thank you.
Next, Dr. Avadhi Ganasava, please be ready. Is she present? Dr. Avadhi? Dr. Bhumi? Dr. Bhumi?
Bhumi Chandrana. Dr. Reshma. Sushank.
Dr. Sushank? Okay, you please be ready. Dr. Pragati, please start.
Good evening, everyone. The topic of my presentation is traumatic cataract, clinical profile, and prognostic indicators of visual outcome in a tertiary care hospital. There are no conflicts of interest or financial disclosures. Trauma is one of the major causes of visual impairment and ocular morbidity, especially in children. Blunt and penetrating trauma have devastating consequences, particularly for the anterior segment. It requires early, meticulous, and multi-stage procedures. Both closed globe and open globe injuries may have traumatic cataracts. Open globe injury should be repaired primarily, followed by cataract surgery. Traumatic cataract surgeries can not only be surgically challenging but also have a guarded visual result. With the presenting visual acuity being a crucial prognostic indicator, other factors deciding the final visual outcome include the mode of injury, the zone of corneoscleral tear, involvement of the visual axis, and a myriad of other factors that this study aims to identify. So the aim is to determine the demographic and clinical profile and visual outcomes in patients with traumatic cataract presenting to a hospital. It is a retrospective study done at AIIMS Patna. Patients with traumatic cataract presenting to the lens cleaning department of ophthalmology of all the age groups were included. Consecutive recorded data from the lens cleaning files was taken, and a total of 43, by mistake it's written, 43 eyes with traumatic cataracts were analyzed. For qualitative parameters, chi-square test or Fisher exact test was performed.
You have written 40.
I've written 40, sir, but it's 43. It's here, sir. So all the patients who were registered in the clinic were taken, the clinical data was extracted, and the data was tabulated in Excel sheets, and appropriate statistical tests were applied. So the primary outcome was to identify the proportion of traumatic cataracts with the final visual outcome as moderate to severe visual impairment. And among secondary outcomes, we had the description of the age distribution, the gender distribution, the proportion of various modes of injury, and the various associated ocular findings, and qualitative description of the spectrum of complications. So the clinical profile that there'll be multiple pie charts that I'll be going through, and under these headings: age and gender, the mechanism of injury, the type of injury, the presenting vision, corneal involvement, scleral involvement, the lenticular involvement with anterior lens capsular breach, among others. So this is just a collage of the pictures of the traumatic cataracts that I presented. So as we can see in the first pie chart, the maximum number of patients were pediatric with age between 0 to 10 years, 33% were those, and followed by 28% with the age group of 10 to 20. There was a male preponderance with a ratio of 3:1. The type of injury was roughly equal for us. Open globe and closed globe were almost similar, and the mechanism of injury is tabulated here, with the maximum being because of a ball or a wooden stick, and there were various other among those. Corneal involvement was seen in 54% cases involving the visual axis, and 45% cases away from the visual axis. Anterior lens capsule integrity was breached mostly in open globe cases, which was 85%, and in closed globe it was 15%. Lens subluxation and posterior segment complications are tabulated here. Subluxated lens was seen in 8 cases in closed globe injury, and in a single case in open globe. Posterior segment complications that we came across was a single case with retinal detachment, 3 cases with vitreous hemorrhage, and 1 case with intraocular foreign body. Coming to the surgical aspects, most of the patients had undergone phacoaspiration with a PCIOL implantation, followed by secondary IOL, and there were 2 cases who underwent scleral fixated IOL. CTR was used in most of the closed globe injury cases, 8 cases of closed globe injury and 1 case of open globe injury. This is the visual outcome. So almost all the patients of closed globe injury had moderate to severe visual impairment, and we could reduce that to 23% at the 3rd month follow-up. This is a similar thing for open globe, 100% previously preoperatively, and half of them could retain a better vision. So age distribution showed a predilection to children, 61% cases were there, with a male preponderance. Open globe and closed globe had roughly equal distribution, and the mode of injury was maximum for ball, with a ball and a wooden stick. Of all the open globe injuries, corneal involvement was seen in 54% cases. ALC rupture was seen in 50% cases in open globe and 9% cases in closed globe. Prognostic indicators were presenting visual acuity, presence of corneal scar, age, duration between initial trauma and cataract surgery, the posterior segment complications, One case had uncontrolled IOP that required trabeculectomy later. Lens subluxation was more common in closed globe injury, and posterior segment complications were also noted. So the limitations include, it's a single center study, there were certain patients who were lost to follow-up, and there was paucity of documentation in certain other cases. Trauma is an important cause of visual impairment, and meticulous preoperative and intraoperative examination can help in providing a good visual outcome. These are my references. Thank you.
Were the patients of cataract managed in the primary setting only or secondary?
Secondary, ma'am. Minimal intervention was done only when ALC breach was there, and if that lens matter was touching the endothelium, only then we did a cataract surgery at the time
Immediately.
of preservation. Yeah, we deferred otherwise.
Okay.
What is the most important examination before performing traumatic cataract surgery?
Status of the posterior capsule should be assessed.
Most important examination before doing medico-legally important.
Posterior segment evaluation, doing a B scan, performing a ultrasound B scan. And if there is a certain pathology, we can perform the surgeries under a guarded prognosis and counsel the patient accordingly.
If you don't do posterior segment examination, B scan, and later on you find
there's a macular scar, or
then
okay.
how will you explain it to the patient?
So these surgeries should usually be performed under a guarded visual prognosis, since trauma, as we all know, can affect all the, from anterior to posterior, can have multiple complications. So all of those aspects should be discussed with the patients, and there is certain amount of improvement that can happen following cataract surgery, and accordingly we should counsel.
How can you suspect retinal detachment before surgery without B scan?
So the tone of the globe, hypotony is associated with RD, so
PR.
PR, most important.
No, one case you have shown that it didn't improve. One case is there where the PL is there before and after.
Yes, sir. That one case, actually, that patient had a macular scar at that time. There was macular, that was associated with intraocular foreign body. He had a metallic foreign body, and it had, in that case, we had done lens aspiration along with corneal perforation, because all the lens matter was in the AC and was touching the endothelium. So 3-4 days later, when we did a B scan, we could see a metallic foreign body. He was giving history as well. So we went ahead with VR surgery, and IUFB was taken out. There was a lot of scarring at the macula. It was sitting right at the macula in that case.
Fine. Thank you.
So now I request Dr. Sushank Balerao for his presentation on fish hook injuries.
So good evening everyone. I'll be speaking.
Just 1 second. Dr. Reshma is there. Yeah, please come and occupy the podium. In the meantime, Dr. Sushank, you can start.
Okay. Good evening everyone. I will be speaking on fish hook injuries, various techniques of removal and largest case series from our institute. I have divided my presentation into introduction, approach to a case, methods of removal, followed by largest case.
It's a 5-year-old child with trivial trauma. As you can see, both the eyes, there's a like almost popped out picture. And she had just fell from the cot, and this is how she got, and she also had a large scalp hematoma, and we suspected a bleeding disorder, and the saving grace was her pupillary reactions were normal, although there was a lot of exposure keratopathy. And factor 13 deficiency was found, and cryoprecipitate was transferred, blood transfusion was given. The anesthesia was high risk because of the bleeding disorder. Lateral canthotomy was done. The extreme chemosis for that conjunctival incision was done, and this subconjunctival fluid was drained out using a periosteal elevator and a muzzle hook. And after this reduction of the subconjunctival fluid, that's the extreme chemosis, the globe was reposited inside using a periosteal elevator. Desmars can also be used according to literature. And a temporary suture tarsorrhaphy was done on the lateral side. Same was repeated on the medial side as well. So you can see the same thing is done on the medial side. Center I have not taken because cornea will get injured. On third day the sutures gave away. We did the same procedure again 2-3 times, and 1 month later this is how she was. 3 months later from here to this position with the factor 13 and all. She developed a little corneal haze, but she got 618 vision with a good near visual acuity as well. So this was the first case involving both the eyes with trivial trauma. And this is the second case with a road traffic accident where the globe had luxated outside. A similar procedure was done. Here also lateral canthotomy was done, and what I want to tell is this lateral canthotomy will be left like that. We will not suture it in the primary setting. And again, here this patient was PL negative and pupil was completely dilated. The aim of the surgery here is to preserve the globe. Definitely the vision is not there, but to preserve the globe, the extraocular muscles had got disinserted in this case. And same way, the lateral and medial tarsorrhaphy, leaving the central cornea unharmed was done, and this is the immediate 1 week post-op, and this is 3 months post-op, and you can see here extraocular muscle disinsertion and all, and corneal thing. Surprisingly, this patient did not develop anterior segment ischemia in spite of the extraocular muscle detachment, and he is due for squint surgery as well as the repair of the lateral canthus and the lateral tarsal strip procedure. And this is the third case of spontaneous globe subluxation in a craniosynostosis baby, the Krausen syndrome. And one eye, again here, the chemosis is the thing which prevents the eyeball to go back. A similar procedure was done. And here also it was 2 to 3 times that we did the same procedure. And she is due for a skin graft, which I am telling in the next case how we manage. And this is a case for bulgur injury and with a large amount of laceration on the lateral aspect and also extraocular muscle tear and all. So even in this case, it was managed similarly, and again there was wound gape, and we did the same procedures again and could salvage the eyeball. This is again another craniosynostosis case. I'm sorry, the pre-op picture is missing. So here what I have done is all the 4 lids I have put skin grafts to additionally add tissue because the orbit is shallow. There is no way to give volume, so skin grafts were added on all 4 lids and lateral tarsorrhaphy was done, and this is how he is. So the globe can be either partial or complete luxation, and etiology is usually traumatic and sometimes spontaneous also, and usually any object entering in the medial orbital wall is the cause, and sometimes optic nerve avulsion is also possible. So one of the things many people resort to whenever there's globe luxation is to enucleate, so that is something which has to be avoided. Although vision cannot be salvaged, it's a very big mental trauma for the patient to lose his eye as well. So we have to do all to prevent enucleation. We can do the temporary tarsorrhaphies and all and preserve the globe, and later for the cosmetic thing we can again do squint surgery and lid surgeries and give a good cosmetic outcome. Thank you so much. And these are the references. Thank you.
Was there any associated orbital wall fracture or any meshes used for?
No, ma'am. These patients did not have orbital wall fracture. So the basic thing in globe luxation they tell is the severe contracture of the peripheral orbicularis oculi. Once the eyeball comes out, the orbicularis contracts and then it prevents the eyeball to go back. So these patients did not have fractures. We did have one bear attack in one lady where it had gouged out the eye in one, and the other severe fractures were there. But there the eyeball was dangling, so there was no support, and I enucleated. That is the one case where I did enucleation. But these cases did not have fractures.
Okay. It's a large series. I really congratulate.
Thank you.
You
So
are
much.
very nicely done, Apun. Thank you very much.
Thanks a lot, sir. Thank you so much.
Yes, you can start.
Good evening, everybody. I shall be talking about laser-induced ocular injuries. I have no financial interest to declare.
Sanskrit, you can come this side, please.
The applications of laser in today's era is in the healthcare, manufacturing industries, military and entertainment. And most of the laser-induced ocular injuries are because of misuse of handheld laser pointers by children or those used in the military, misfire of laser during cosmetic procedures, or laser-induced ocular injuries because of decorative lights in festivals and in concerts. According to FDA, 5 milliwatt is a standard for lasers and laser projectors used during laser light shows. I shall be presenting one of my case by means of an animated explainer video.
Hello, I hope you all are doing
Can I have
well.
the video,
I
audio,
am
please?
Dr. Jay. I am gonna share with you an intriguing case today. So let's get started without an ado. A 28-year-old female dermatology PG resident presented to us with complaints of diminution of vision in the right eye for the past 3 hours. She gave history of unprotected exposure to Q-switched ND-YAG laser, which is used for cosmetic procedures in dermatology. Her best corrected vision in the right eye was 1/60 while in the left eye was 6/6. Anterior segment was within normal limits in the right eye. But to our horror, her right eye fundus picture looked like this. A large retinal hole caused by laser burn, approximately 4 disc diameters in size, located supratemporal to the macula. The hole was seen to bleed fresh blood into the vitreous cavity. Decision to barrage the hole with retina green laser was made. The patient was given anti-inflammatory medication and was asked to maintain a propped up position and to avoid coughing and straining. The patient returned 3 days later with a BCVA of 6/6 parts showing resolving vitreous hemorrhage. Barrage laser marks could be seen all around the hole except for the inferior border because of obscuration by the downflowing thick blood stream. So in this visit, barrage laser was completed and the patient was asked to take the similar precautions as described before. 1 week later, the patient continued showing signs of improvement with resolving vitreous hemorrhage and a well-barraged retinal hole. 3 weeks later, patient was back at BCVA 6/6. She has been advised regular retina evaluation to look for development of complications like CNVM and ERM. She was advised to always wear safety glasses while doing a laser procedure. Hope you found this case worth your time. We would love to.
So laser injury during the cosmetic procedure in a dermatologist is very rare with very few prior case reports. Q-switched ND-YAG laser has a wavelength of 1064 nanometer and it penetrates into the deeper regions of the skin and it destroys deep-seated dermal melanocytes by selective photothermolysis and therefore is used by dermatologists to treat nevus of ota and hori or to remove the tattoos. Lasers are widely used in cosmetic medicine, scientific research and industry. The eye can be injured during cosmetic laser procedures involving the face. Accidental laser discharge during the preparation of laser device is the most common cause of laser-induced retinal injury, and the lack of use of protective goggles is another one big reason. The laser light wavelengths between 400 and 1400 nanometer can damage the retina as they can be transmitted through the clear media of the eye. Higher wavelengths and shorter pulse durations cause more severe mechanical damage to the retina. The factors of the laser beam include high directionality, energy, irradiance, coherence and power, which can cause high intensity damage to the retina, and the severity of retinal damage depends upon the wavelength, duration of exposure, spot size, power and location. The site of damage depends upon the energy. If it is less than 1.4 millijoules, the RP is affected. If it is of the order of 1.9 millijoules, RP, neurosensitive retina and Brooks membrane is affected. If it is around 2.8 millijoules, then whole of choroid and retina is affected. There is disruption of the choriocapillaries, Brooks membrane and the RP when there is injury by Q-switch ND-YAG laser. And the RP absorbs the energy directed by the laser, which leads to tissue ionization and plasma formation, followed by an acoustic shock wave, which leads to mechanical disruption of the retina. The manifestations could include preretinal, interretinal, subretinal or vitreous hemorrhage, macular hole or peripheral retinal holes, and foveal burns. This is another 19-year-old patient who was attending a disco party, and he had the history of looking directly at the laser light, and he presented to us with a small sub-ILM bleed, and his vision was 636 at presentation. And we just observed the patient, and in a matter of 1 month he improved back to 6/9. This is another patient who gave similar history, and he had just subtle changes at the ISOS level, photic maculopathy. The complications include choroidal scarring and CNVM and ERM.
Your
and the
time
prevention.
is out, Doctor.
I'm done. Thank you. Thank you.
Hello, you can start. Sanskriti.
Epidemiological profile of patients presenting with the traumatic corneal laceration at the tertiary healthcare center of the North India. Dr. Sanskriti.
Good evening, everyone. Before commencing, I would like to thank the Haryana Ophthalmological Society and the All India Ophthalmological Society for this opportunity. My topic is clinico-epidemiological profile of patients presenting with traumatic corneal laceration at a tertiary healthcare center of North India. Injury to cornea can result from trauma, typically from a metallic, plastic or other object impacting and breaching the corneal layers. Clinical features include acute, severely painful eye, with lacrimation, photophobia, and impaired vision. Corneal laceration can lead to the development of ulcer, followed by an opacity, which is a significant cause of ocular morbidity. Aim was to assess the epidemiological factors like age, mode of injury, causes, clinical features, management, and outcomes in patients presenting with traumatic corneal laceration to a tertiary care institute of Haryana. Objectives included to find out if there is any association between mode of injury with the final visual outcome, and to assess if there is any association between the presenting visual acuity and the final visual outcome. A retrospective case study was done after taking permission from Institute's Ethic Committee in patients presenting with traumatic corneal laceration to trauma center and ophthalmology OPD at PGIMS Rohtak and underwent emergency surgery. Medical records of these patients between April 22 to 23 were taken into account and reviewed. Inclusion criteria was patients with complete records who presented within 24 hours of trauma, and patients with a follow-up of less than 6 weeks were excluded. The following details were taken into account: personal details and demographic details, detailed history including chief complaints, history of presenting illness, past history including the use of spectacles, trauma, surgery, etc. Ocular examination included unaided visual acuity and best corrected visual acuity with age-appropriate refraction, ocular adnexa including eyebrow, eyelids and eyelashes, anterior segment examination including cornea, conjunctiva and pupillary reaction, fundus examination was done. Corneal laceration repair was carried out with 10-0 nylon sutures under GA for children and under LA for adults within 24 hours of presentation. Post-operative findings were noted at 1 week and 6 weeks, which included visual acuity, status of sutures and any other complications. Results revealed that data of total 30 patients was taken into account, out of which 60% were males and 40% were females with age ranging from 2 to 47 years and a mean age of 15.28 years. 60% of the patients were aged less than 10 years, as can be seen in the bar graph. This is the pie chart demonstrating percentage distribution of different modes of injury. It should be noted that wooden stick is the most common mode, followed by roadside accident. This is a table demonstrating visual acuity at presentation and at follow-up of 6 weeks. It should be noted that patients who presented with a better visual acuity demonstrated final better visual outcomes. After 6 weeks of follow-up, visual acuity of up till 660 were achieved in 30% patients. There was a statistically significant correlation between the presenting visual acuity and a final visual outcome with a p-value of 0.002. However, no statistically significant correlation exists between age, sex and mode of injury with the final visual outcome. 16.67% patients developed endophthalmitis and underwent conservative treatment. Our study revealed that corneal laceration is more seen in children. This is consistent with findings of Bairaju AM et al. In Nigeria. Malika et al. And Grishbar et al. Conducted similar studies in 2009 and 2006 and found out that most corneal laceration occur as a result of wooden stick injury and roadside accidents. This is consistent to findings in our study. However, our study differs from the above that all patients presented within 24 hours of injury and were repaired within 24 hours due to round-the-clock emergency OT services and a great anesthesia backup. Owing to this, our patients achieved better visual outcomes. The limitations of our study was a small sample size, retrospective nature and a short follow-up. To conclude, traumatic corneal laceration is a significant cause of uniocular morbidity and visual impairment. Urgent diagnosis and timely management can prevent disastrous sequelae like corneal blindness and endophthalmitis. Formation of an urgent referral trauma team and strict legislative guidelines along with public eye health education can optimize the visual outcomes. These are my references. Thank you.
Thanks a lot. Wonderful study.
The lacerations you mentioned, were they partial thickness, the oblique, the
They were all, ma'am, full thickness.
full thickness, yes, and were they associated with iris prolapse associated?
Yes, ma'am. It
That
was,
is not
although it was
mentioned.
associated, but we have not included that in our study.
Nice study which you have done, but your rate of endophthalmitis is pretty high, 16-17%.
Yes, sir. Actually, some of the patients, they were from a very poor background. They were not compliant with the medications despite counseling them properly. Most of these patients were belonging to the rural background. We tried to help them out, but
it's not that. Basically, did you do B-scan at the time of the presentation? And
No.
because it was done in emergency hours, I think investigation thorough investigation should be done in all these cases. And if there is an involvement of posterior segment at the very first instance, then you have to give intravitreal vancomycin and maybe voriconazole, looking to the type of. So that is what is the dictum to be followed, and that will decrease the endophthalmitis incidence. So first thing, or early detection of endophthalmitis, which will decrease the load of bacteria and fungus in the.
How much was your follow-up in this? How frequently you have called them for follow-up?
Sir, on post-operative day 1, day 7 and 6 weeks.
So you could not pick up on the day 7?
Sir, in between also we had called for follow-up of 2 weeks also, but not all patients came. But most of them came at 1 week and 6 weeks. That's why I have included that data.
Thanks.
Thank you, sir.
Are you through with the mark sheet?
Yes. Instructions. Look at
ये इसमें से भी डिक्लेयर करना है, आप कॉल करोगे, दोनों का प्रेजेंटेशन लेना है फाइनल सेमीफाइनल। अभी करना है कि खाली डेमो करते हैं? फिर इन लोग को क्यों बुलाया इसको? सेमीफाइनल को क्यों बुलाया?
ये अभी करना है क्या?
ऐसे कैसे करेंगे? किसने बोला? मेरे को
देख
बात
लो,
कराओ ना।
कर लो, अगर करना है करवा लो।
चलो,
अगर बोला है
तो पहले वाले का
नहीं सर, एक और लेट शुरू होता है, आप ले लेते हैं। कम मारिया, प्लीज कम।
को हाइड पार्क में जाना है।
ओके, ठीक है, ठीक है। You have been called up by the committee to represent it now. Yeah, मैडम आप बैठिए।
9-4.
सर 5 मिनट, सर एक 5 मिनट का कॉल है खाली।
इस वाले का पहले रिजल्ट करो।
हाँ,
इस वाले का
अच्छा,
ये तो कर रहे हैं, कैलकुलेट करके फर्स्ट कौन है इसमें तो बताओ ना। नहीं, बट डिफरेंट पैनल here, that's why. Do it quickly. Tale of 2 traumas, visual outcomes and closed globe injuries with and without head trauma.
231.
You can start.
051 81.
IT team just open, no? Free paper 1546. 1546.
Serial.
ये फर्स्ट सेशन के विनर है, उसको कितने मार्क देंगे डिसाइड करना है।
ये कहाँ चलेगी? लास्ट वन।
वो लास्ट वाले चले
Should
गए।
have been there for 5 minutes. क्या करो?
Can I start?
Yeah, please start. Sir, please start, na? Yeah.
Good evening, everyone. I'll be presenting a tale of 2 traumas, which is comparing the visual outcomes in closed globe injuries with and without head trauma. Ocular trauma has a wide variety of presentations, ranging from a contusion to a globe rupture, and patient presenting with a vision of 6/6 to a patient with no perception of light. Our aim of the study was to analyze the influence of head trauma in the visual outcomes of patients with ocular trauma. We included only closed globe injuries. It is a cross-sectional study of duration 3 months. Our study included 300 patients who had ocular trauma or closed globe injury, out of which 150 patients were divided into group 1, who had a concomitant closed globe injury and head injury, and the other group 2 had only closed globe injury. Age group of 18 to 65 years was included. Patients with severe head trauma, GCS less than 9, and open globe injuries were excluded. Visual acuity during the first presentation of the trauma and at the end of 2 months was recorded. We took into account the factors like head injury, a lid injury, and bony orbital wall involvement, and their influence on visual outcomes in both the groups was analyzed. Coming to the results, the age in both the subgroups was a younger age group, less than 30 years, and a male preponderance was noted in both the groups. The major causes of closed globe injuries in both the groups was road traffic accidents. The patients who had ocular trauma and a concomitant head trauma presented with papilledema being the most common, whereas in group 2 it was a subconjunctival hemorrhage. We also found an impact of GCS on the visual outcomes, in which patients with mild head trauma, that is GCS more than 12, 56% of the patients showed a visual acuity improvement, whereas in patients with moderate head trauma, only 38% of the patients showed an improvement in visual acuity. Visual outcomes in patients with papilledema, in group 1, 27% of the patients, and in group 2, all 100% of the patients showed an improvement. Here, we also explained that in group 2, the disc edema can be due to the bilaterality of ocular trauma, which disappeared by 2 months, and the exact origin may not be diagnosed by an MRI or CT brain at the time of presentation. Incidence of RAPD, 21 patients presented with RAPD in group 2, whereas 42 patients presented with RAPD in group 1. Visual outcomes in patients with RAPD was analyzed, in which the 21 patients in group 2 who presented only with an ocular trauma had an intraorbital or canalicular portion injury in the optic nerve, and orbital nerve decompression was also carried out, but 3 patients did not show any improvement. We also, as previously mentioned, we analyzed whether bony orbit involvement has an impact on the visual acuity improvement. In group 1, it was a blowout fracture being the most common, and in group 2, it was medial wall fracture, and the table also shows the percentage which showed a visual acuity improvement. Also, we analyzed the visual outcomes versus lead involvement in both the groups, which shows that 56 and 74% of the patients respectively showed an improvement in visual acuity. Coming to the discussion, presence of head trauma in patients with papilledema was a poor prognostic factor. The presence of RAPD in patients with head injury had poor visual outcomes, and the results were statistically significant. In our study, we also found that bony orbit involvement, though it affected the visual outcomes in both the groups, but the results were statistically insignificant. And as previously mentioned, lid injury did not have any impact in the visual outcomes. That is, patients improved with a good visual acuity. These are the take-home messages from our study. We conclude that head trauma, when it happens along with an ocular trauma, has an important prognostic significance. We used GCS as a scoring to assess the general prognosis. Presence of papilledema in the presence of head injury in patients with ocular trauma is a grave prognostic factor. RAPD in association with head trauma is a more ominous sign. Bony orbit involvement, if present along with head injuries, though it decreases, but in our study it was statistically insignificant. Lid injuries does not decrease the visual outcomes, whether there is a concomitant head injury or not. So we conclude that papilledema, RAPD and bony orbit involvement are the factors which predicts the visual outcomes who had a concomitant ocular trauma and head injuries. These are my references. Thank you.
Thanks a lot for the second presentation. I was chairman for both the sessions. They will be giving the marks, we will notify you. Thanks a lot.
Thank you, sir.
Any questions you'd like to ask, both of you? Okay, fine.
Thank you, sir.
We are at the end of the session. Of course, we have done the first of the semi-final. The other person, we are just awaiting the results. So the second group was there from 4:20 to 6. Just wait for a few minutes. They said that we are going to give the results. The finalists will have to present it in front of the panelists. So we go ahead and finalize who is the winner of the 2 sessions. आ रहे क्या? Go through, sir.
Sure.
75.
So we have this. We will have to put it in an envelope. Then envelope चाहिए. Envelope. उसको पूछो ये रुके. हमको भी जाना है इनॉग्रेशन को. नाम भी डाल देना सर नीचे. मोबाइल नंबर 8
सर
आज का हॉल 2B. हाँ इसको तो मार्क्स दे दिया ना ऑलरेडी. ये तो दे दिया हमने. अभी इसमें ये तो
दूसरा लगेगा ना.
आ रहा हूँ, खत्म हो गया, आ रहा हूँ, आ रहा हूँ.
अच्छा ऐसा
आ रहा हूँ ऊपर में
ये
सेशन
इसका
में
क्या
आ
है? ये
रहा
तो
हूँ.
ये वाला भी ओके.
वैसा विनर कैसे का डिसाइड होगा? जो
winner
पहले
नहीं
सेशन
देंगे.
का एक
ये
है.
कैलकुलेट करके फिर करेंगे लोग. दे हैव देयर ओन मेथड.
Okay.
You don't hold it. Names.
Hello.
हाँ.
Sir, give them.
हाँ बोलिए, थोड़ी देर के बाद बात कीजिएगा, अभी बिजी हैं।
इसमें ही डालना है कि एक ही एनवलप में भी? Anyway, thanks a lot everybody. They are going to follow this procedure. They'll let you know the results later on. Thank you very much. Please join us for the inauguration. Hall A. Thanks a lot. Once again, I
Congratulate
Scientific
all
Committee,
presenters.
Dr. Namrata Sharma and the AIO Scientific Committee for giving us a chance to do the judgment of Trauma Series 2 also. Thanks a lot once more. Thank you very much on behalf of the panelists. Both of you, thanks madam for waiting. For sir also, you too. Thanks a lot. And all the best to all the presenters. Thank you very much. And the audio-visual people and what the coordinator, hall coordinator. Thanks a lot. भाई फैन बिठाओ यार इधर, फैन ही नहीं है, पूरा पसीना पसीना कर रही है इधर जजिंग करते।
Thank you, sir.